Today we're going to discuss atrial flutter. I want to first start out with reminding you guys about the normal conduction pathway. Most patients should start out in the right atria at the SA node. The next will be to spread across the atria, reach that AV node, hit the bundle of His, and travel down the right and left bundle branches into the Purkinje fibers or the ventricles. With atrial flutter, it's a little bit differently. There are short circuits that cause the upper chambers of the atria to fire more rapidly. Research has said that it can be 350 beats per minute. So what you get is these irritable foci within the atria that are continuously firing. Not all of them we want to reach the ventricles because we would never want a ventricular rate over 300 beats per minute. So the AV node acts as that gatekeeper and prevents those impulses from actually reaching the ventricles and causing that high ventricular rate. We have to make sure that we don't allow too many to go there. If there is, then what happens is the patient can experience a plethora of symptoms. It can be palpitations, shortness of breath, dizziness, as both of these chambers, the upper and lower, are competing against one another. Some of the treatment modalities that you guys will see are dependent on the severity. They can include medications such as diltiazem. Diltiazem works on that AV node to make sure that not too many impulses get to the ventricles, whereas amiodarone is an antiarrhythmic and it works to kind of reset that heart at the SA node. If the medications don't work and the severity increases, then we know that we can use synchronized cardioversion. And synchronized cardioversion is just to briefly stop the heart in hopes that it resets at that SA node and fires in normal sequence. If that doesn't work, then we also have procedures such as ablations, and the goal of that is just to ablate out that abnormal tissue that's causing the issue. We know with atrial flutter, just like atrial fib, these patients are at risk for blood clots. So we want to make sure that we control the rate and prevent the clots. That's the most optimal treatment. When you're thinking about how you're going to do some of the measurements, oftentimes you are going to see a narrow QRS. We're not going to be able to measure a PR interval just because there are too many P waves, and we can't figure out which one we need to choose. So we do not do a PR interval. And then the P waves are going to present in flutter waves, also known as sawtooth. This is probably the most common one that you're going to hear. So if we want to look at some of the examples, when we see the top one here, we have these sawtooth waves here. Most of the time, atrial flutter will be regular if we were to measure the R to R. The rule of thumb is you kind of count the humps and add one. So if I did 1, 2, 3, add 1, it would be a 4 to 1 conduction. 1, 2, 3, 4 to 1 conduction, and so on. So this patient at the top one is pretty consistent with having a 4 to 1 atrial flutter. The ventricular rate is super important in atrial flutter, and so with this, 1, 2, 3, 4, 5, 6, 7, 8, the ventricular rate is 80, so very manageable. If we look at this next one here, you can see that we have this sawtooth, but they're a little bit different. So you do see some kind of irregularity. 1, 2, 3, this is like a 4 to 1 again. But I look here and it's probably like a 2 to 1 conduction, 4 to 1 back here. And so we don't necessarily say it's irregular, but we do say that it has variability. This bottom one is a 2 to 1 flutter, and this is probably one of the most missed rhythms that can occur. Oftentimes we suspect that it's tachycardia because you can see this, that we have the P wave as well as the T wave. But if we look a little bit closer or try to rule out sinus tach or reasons why the patient might have sinus tach and they don't, then oftentimes it is an atrial flutter at a 2 to 1. So the rates are going to be a little bit faster. Oftentimes we will do a 12-lead EKG to confirm. And the other option is you can have your monitor techs speed up the sweep of how the rhythm strip comes out. And so what you guys will see is actually a rhythm strip that's kind of extended out that looks a little bit slower, and you can delineate if it's a sinus tach or an atrial flutter 2 to 1.